Hi, Dr. Walker. I wanted to follow up with regards to patient Mr. Brown upon review of his medication order. To recap, Mr. Brown is a 78-year-old patient presenting with 2-day new onset of mild disorientation as well as malodorous and cloudy urine. He is suspected to have a urinary tract infection. Most of his vital signs are normal. To note, temperature is 36.8 degrees Celsius with no indication of fever. Of concern, ambulatory blood glucose measured today was 14 millimole per liter. Mr. Brown has type 2 diabetes and hypertension. After suffering a stroke last year, he was diagnosed with mild dementia and developed impaired mobility. A urinary catheter was put in place to reduce risk of falling if he had to walk to a washroom. At present, his signs and symptoms are not definitively diagnostic of a UTI, and he should not be started on Cipro 500 mg BID as ordered. Cloudy or foul-smelling urine is not indicative of a UTI. Dipstick testing is also not an appropriate diagnostic test for catheterized patients because the presence of a catheter invariably induces pyuria without the presence of infection. Based on current guidelines, diagnosis requires that urinary cultures show at least 10 to the 3 colony-forming units per ml and that other signs be present as well, such as fever, rigors, altered mental status, or suprapubic pain. Since altered mental status, which Mr. Brown is experiencing, is a non-specific symptom, it should not be the only presenting symptom when diagnosing catheter-associated UTIs. Changes in mental status can be caused by alternate site infection or several non-infectious causes. As such, Public Health Ontario's UTI program no longer considers delirium as an accepted clinical sign of UTI. Before diagnosing and treating Mr. Brown, all plausible causes of his altered mental status must be considered and ruled out. Hyperglycemia and electrolyte abnormalities can cause changes in mental status, so these would be appropriate starting points for further investigation. Mr. Brown's electrolyte levels will be imperative in determining causation, and close monitoring of his vitals over the next 24 hours is also paramount. If UTI is still the diagnosis at this point, I can offer some insight on antimicrobial selection. Ciprofloxacin 500 mg BID for 7 days is an appropriate first-line regimen for complicated UTIs. However, drug-induced antimicrobial resistance and C. difficile are greater concerns with fluoroquinolones than with other indicated antimicrobials. Therefore, I would not recommend this regimen. Alternatively, I would recommend Septra-DS BID for 7 days, which is also first-line with lower risk of collateral damage. In terms of UTI preventative measures, for the team to consider, I would recommend a review and reassessment of Mr. Brown's catheter use. If appropriate, the catheter should be removed. A major risk factor for UTIs are indwelling catheters, so if we can eliminate this risk for the patient, it could reduce future incidents of UTIs and reduce antimicrobial use as well. Thank you for your time, Dr. Walker. If you have any questions or would like to discuss the patient further, I will be here all day.